Good morning. Happy Tuesday. I have Neuro Coffee in hand and it is perfect. All right. Man, I'm feeling a little stressed this week because we're going to go on vacation in a few days, and so you always have to get like everything done before you go. And so I'm cramming a bunch of stuff into this week, and I got a big question today, so I'm going to dive right into this. And it comes from, it's either Stephen or Stefan. It's got the PH in there, and I never know what to do there. I grew up with a kid, and we called him Stephen, and he had a PH, so I'm going to call you Stephen if that's okay. If I screwed that up, just let me know. But it is a great question. So Stephen asks, what are some non-surgical strategies for addressing ulnar nerve hypermobility? Does this often coincide with very depressed shoulders, and how might these be related? Is it a lack of shoulder internal external rotation? That's a factor that drives this. How does supination and pronation and biceps and triceps come into play? I know there's a lot of sub-questions in there, but I would just love hearing your perspective. So first and foremost, appreciate that. But this is a great question because I think it's horribly misnamed. I think that we always have to remember one thing, that people are horrible at naming things. And then by calling this thing ulnar nerve hypermobility, we get distracted by what's really going on. So now we're blaming the ulnar nerve for something that it can't even do. So we don't blame a train for following a track. And in this case, the ulnar nerve is the train, and it's just following a track. And so if we change the track, then the behavior of the train changes. And so that's what we're looking at in my estimation of the situation. So Stephen, we've got an orientation problem and we've got a shape change problem. So the first thing that we want to understand is that we do have a very specific shape to the cubital tunnel that typically exists. So we have the medial epicondyle, and along with the rest of the elbow structure, making this nice squared off cubital tunnel that allows the ulnar nerve to move through its normal groove. But if we have something that would change the shape of that tunnel, and I think that we do, then we're going to have the ability of this ulnar nerve to move a little bit differently. So rather than having this nice squared off shape, what we end up having is it becomes more of like a half moon kind of a shape, or a little bit more curved, which allows the ulnar nerve to slide up and out of the cubital tunnel as we flex the elbow. So these symptoms typically show up around 90 degrees of elbow flexion, which is where we put a lot of tension on the ulnar nerve. So the ulnar nerve has to bend around the elbow at this 90 degree point. And if it doesn't have this squared off rigid tunnel to hold it in place, it's just going to slide up and out, and that's basically what happens. So if we look at this thing from the orientation perspective, first and foremost, we're going to have a proximal to distal influence, and then we're going to have a distal to proximal. So proximal to distal, we're going to have a loss of shoulder internal rotation under most cases, and so we're going to get an orientation of the humerus into external rotation. Now, because of this, the proximal forearm is actually going to follow the distal humerus into external rotation. And so this is actually a really big deal. What we end up with then is we get a posterior lateral compression. So we get concentric orientation of anconeus, we get a concentric orientation of supinator, which twists the proximal forearm into supination. Now, we also have to remember that I have a pronator on them that attaches directly to this medial epicondyle. So pronator teres attaches to the radius. So if the radius is trying to move into supination, it's going to pull the distal attachment of pronator teres along with it. And guess what? It's going to also pull the medial epicondyle. And so now I've got multiple forces that are twisting this distal humerus into external rotation. This is what's going to flatten out the cubital tunnel. It's going to change the shape of the cubital tunnel. It's going to allow the ulnar nerve to slide out. It's going to cause a whole bunch of medial stress on that elbow. Now, distal to proximal. Because I have to pronate my hand in any number of cases. If I'm keyboarding, I have to pronate my hand. But a lot of times we relate this to baseball. This is a really good representation for baseball, because when I release the ball, I actually have to pronate my hand and my distal forearm So I get a lot of pronation that's coming from distal to proximal. So proximally, I'm trying to ER, supinate. Distally, I'm trying to pronate. So I get this perfect storm of twist, which keeps tension on that pronator teres, which pulls the medial condyle. And again, we get that shape change at the medial elbow. And so what this ends up looking like is, so people will get accused of having an increase in the valgus elbow. It's not a valgus, it's a twist. Go back to the valgus elbow video from a while back and you'll get that explanation. They'll get accused of having hyperextension of the elbow. It's not hyperextension. Again, it's the twist at the elbow that's associated with the concentric orientation and that posterior lateral aspect. So now we actually have a representation of what we're looking at. Let's come up with a solution. So number one, eliminate interference. So we have behaviors that are actually promoting some of these changes. Let me pick on the young baseball players for a moment. You got to stop throwing a little bit, because every time you're throwing, you're actually increasing that distal humeral external rotation. You're promoting the shape change in the elbow, and you're allowing this ulnar nerve to slide in and out of its groove, and that's what creates the irritation on the inside of your elbow. We need to minimize the elbow flexion activity. So the people that are diagnosed with this situation often have a lot of medial elbow pain, but they find that if they keep the elbow straight, it doesn't bother them quite so much. In fact, they'll splint people at night in elbow extension just to take the stress off of this medial elbow. So again, we have to eliminate the things that are actually aggravating. Now, if we talk about a reconstruction, a reorientation, and hopefully a shape change that is favorable, we have to do activities that bring the pump handle up. So the sternum, we have to get anterior expansion through the upper anterior thorax. This is going to give us back our shoulder internal rotation that we need to start to reorient the humerus. If we can't reorient from proximal to distal, we're not going to recapture this elbow position. From there, so we're going to do like reaching activities, stuff at 90 degrees of shoulder flexion with the elbow extended. Again, it's going to be more comfortable that way. To start, we can move to oblique sit variations with elbow extended and start to work on some of this internal rotation, recapturing normal pronation of the forearm to reduce the proximal supination element. We can start to do that. We're going to move down to side plank variations, starting first elbow extended and then again going down to elbow flexed with normal pronation. What I may also have to do is I may have to reduce the pronation influence that's coming distal to proximal. So I'm going to pad up my hand if I'm doing this in elbow flexion. So I've got a shoulder and internal rotation. I've got normal pronation of the forearm, but I'm going to block the hand so I don't get that distal to proximal influence. From there, we can move on to more dynamic activities, but we always have to respect the orientation of the shoulder, the position of the elbow, and then what the hand is driving from distal to proximal. So if we're going to do any form of elbow extension activities, we'll do them in internal rotation, pronation, with a limited amount of hand, right, wrist deviation. So we want to keep this orientation of the hand to the wrist relatively fixed, so we're not driving, again, the distal to proximal element of pronation. Stephen, I hope that gives you at least a place to start, a little bit more understanding of what I think is going on with this situation. And again, let's not blame the ulnar nerve for this. Let's look at the orientations, look at the shape change, because the ulnar nerve is just following along where everybody's given it a new path. So everybody have a great Tuesday. I will see you guys tomorrow.